Hi, I'm Pedro Ferreira, the first author in this study where we try to reduce scan time towards one breath-hold by reconstructing diffusion tensors for in vivo cardiac DTI with a fitting-free deep learning approach. In vivo cardiac diffusion tensor imaging, cDTI, is a promising technology capable of characterizing myocardial microstructure in the living heart. cDTI calculates a diffusion tensor for each voxel, from which multiple parameters can be extracted, including tensor orientation and tensor shape measures. It offers the potential for novel microstructural and functional assessment. However, considerable technical challenges exist to translate cDTI to clinical routine. Single-shot encoding acquisition translates to low signal-to-noise, and therefore multiple repetitions are commonly acquired to build up signal. This is not ideal, as each repetition incurs additional scan time and potentially an extra breath-hold for the patient. Based on the data used here, our current clinical research protocol requires approximately 12 breath-holds for each 2D cDTI slice at a single time point in the cardiac cycle. The series of signal intensities for each voxel is normally fitted to a ranked 2 diffusion tensor by means of a linear least square fitting, or alternatively, by more advanced linear and non-linear iterative methods. In this work, we propose an alternative fitting-free deep learning approach by reconstructing the noise diffusion tensors for in vivo cDTI with the aim of reducing the number of breath-holds needed. We replace the tensor fit with the U-Net. U-Net CNN architectures have been commonly used in biomedical image segmentation problems and adapted here for image generation, in particular the tensor components generation. To train and test the U-Net, we used previously acquired cDTI data. These datasets were acquired using a Siemens Kyra 3 Tesla MRI scanner and more recently a Siemens Vida 3 Tesla MRI scanner. With a diffusion-weighted STEAM EPI sequence, we reduced phase field of view and fat saturation. Diffusion was encoded in 6 directions with diffusion weightings of B150 and 600 in a short-axis mid-ventricular slice. All diffusion data were acquired under a breath-hold with a duration of 18 heartbeats and a 10-second gap between breath-holds. We used a total of 744 cDTI datasets containing a mixture of healthy volunteer and patient scans acquired in either the diastolic pause or end systole. The data distribution per cohort and cardiac phase is shown on the right. The datasets containing all acquired data were used to calculate the reference tensors for each subject using our cDTI post-processing software. We then built 3 smaller datasets that were retrospectively created from the reference datasets by reducing the number of repetitions. We then trained the U-Net to output the same diffusion tensors, but using a reduced number of diffusion-weighted images as the input. We have 4 datasets in total. The reference results, calculated with all data acquired, used here as our ground truth. These were used to calculate the ground truth DTI results with a conventional linear least square tensor fit. And then we have 3 smaller datasets that were retrospectively created by reducing the number of repetitions, named here based on the set number of breath-holds required, 5, 3, and 1 breath-hold only. The reference DTI results were then compared to the DTI results from the reduced datasets when using the U-Net generated tensors and the conventional linear least square tensor fits. The data were randomly divided into 70% for training, 15% validation and 15% testing. The division of scans was stratified to keep a balanced number of cohort and cardiac phase in each of the 3 sets. The compared DTI results are the following cardiac tensor parameter maps: fractional anisotropy and mean diffusivity related to tensor shape and size, and helix angle and sheetlet angle related to tensor orientation. The loss functions plateaued at around 400 epochs. The network weights were set to update only if the validation loss function improved from previous epochs. Here we show an example of the reference and the respective predicted U-Net tensor components for 5, 3 and 1 breath-hold worth of data. An increase in smoothing is visible as the number of breath-holds decrease. We now show DTI parameters for an example from the test dataset, in this case a healthy subject, where the tensor was calculated with an LLS algorithm. From left to right we have the reference gold standard, the 5 breath-hold, 3 breath-hold and 1 breath-hold. The difference to the respective reference maps is also shown in the error maps. As expected, the maps are noisier as the number of breath-holds decrease. The FA map for a healthy heart is expected to show a band of higher FA in the mesocardium. This band was visible in the reference map and in the 5 breath-hold map, but it was harder to identify this feature for the 3 breath-hold and even more so for the 1 breath-hold map. Here we have the same subject, but this time comparing the reference results and the results from the U-Net predictions. An increase in smoothness in the U-Net resulting parameter maps was noticeable as the number of breath-holds decreased. Nevertheless, the higher FA band in the mesocardium was visible for all 3 datasets, including the 1 breath-hold. This figure shows the mean voxel-wise absolute error for FA and MD and mean absolute angular error for AJ and E2A. Each dot represents one subject. For each dataset, it is also shown the median and interquartile range in the gray rectangles. For 3 breath-holds and 1 breath-hold datasets, the U-Net showed significantly lower errors for all 4 DTI parameters. The U-Net was originally developed for image segmentation, although it has also been used for image reconstruction and diffusion image generation. In this work, we show that a U-Net like CNN can also be used to derive the diffusion tensors from diffusion-weighted images. For reduced datasets that can be acquired in 3 or just 1 breath-hold, the U-Net results outperform significantly the conventional tensor fit. Visually, the tensor parameter maps generated by the U-Net have a noticeable increase in smoothness and potential loss of detail. This is very conspicuous, in particular for the 1 breath-hold results. Potential advantages of using a deep learning model are therefore expected for cases where we have a very limited amount of data. One important point about deep learning models is uncertainty. Estimates of model uncertainty are essential before any clinical decision making, aided by this model's results. In terms of limitations, in this work we have a lack of real ground truth results. We have a small quantity of training data for some patient cohorts, including Fabry, hypertensive DCM and Marfan. And finally, all data was acquired in scanner models from the same manufacturer and with a fixed protocol. The generalizability of this model of other scanners and other protocols is currently unknown. This work was supported by the British Heart Foundation and UK Research and Innovation. For more details about the methods and more results, please have a look at the online article. Thank you for watching.